Good afternoon to everyone that's joining us today, and thank you for joining us. Today, we're going to talk about how organizations are using rapid tests of change to accelerate their path to zero pressure injuries. For many teams, the challenge isn't knowing what to do, it's how to implement that change quickly, consistently, in a way that actually drives and delivers outcomes. That's what we're going to be focusing on today. With that, I'd like to introduce you to our speaker, Dr. Rhonda Sullivan. She brings firsthand experience in applying these rapid tests of change to drive meaningful improvements in pressure injury prevention. Dr. Sullivan serves as the Vice President of Implementation and Clinical Outcomes at Bruin Biometrics and brings nearly 3 decades of experience helping healthcare organizations translate best practices into measurable clinical outcomes, particularly in the pressure injury prevention space. As a certified woundostomy nurse, Lean Six Sigma black belt, and a med legal expert, she has spent her career focused on how to implement change effectively at the bedside, making her uniquely qualified to speak on how rapid tests of change can accelerate progress towards zero pressure injuries. Rhonda, I will turn it over to you.
Thank you, Dan. So pressure injuries affect patient safety, system performance, and the financial health of an organization. Today, we'll explore how rapid cycle change can take zero harm from a slogan to an operational goal with better workflows and measurable results. During this webinar, we'll show how QI-based implementation works, what rapid cycle change looks like in practice, how Path to Zero is structured, and the real-world outcomes that teams are achieving. Pressure injuries are often the result of failures in assessment, workflow, reliability, and timely intervention. Traditional prevention approaches rely heavily on subjective skin assessment, imperfect risk strategies, and protocols that are often unrealistic in practice. When I began working in pressure injury prevention 26 years ago, best practice emphasized limiting care bundles to no more than 5 evidence-based interventions. Over time, however, additional interventions have been added with insufficient attention to the supporting evidence, on-label use, or validated outcomes. Today, some prevention bundles include more than 20 interventions for every at-risk patient. This approach sets nurses up for failure and increases organizational risk. No nurse, regardless of skill or dedication, can reasonably be expected to implement 20 interventions for every at-risk patient during every shift. This is precisely why pressure injury prevention requires a different implementation model. That model is the Path to Zero. Path to Zero is a customizable data-driven pressure injury prevention optimization program. It combines strong clinical evidence with Lean Six Sigma-based change management, waste reduction, and implementation support. Designed for senior clinical leaders, it helps improve prevention outcomes, workflow performance, and financial results across the system. Path to Zero is our way of working and how we partner with organizations to make zero harm a reality. The Path to Zero is grounded in the Donna BDM model, a proven framework for evaluating healthcare quality through 3 connected elements: structure, process, and outcomes. Together, these components help organizations assess how care is delivered and how it impacts patient results. Path to Zero uses a proven quality improvement approach to catalyze measurable clinical and operational value. Using rapid change PDSA cycles, we identify practice gaps, address barriers to high-quality pressure injury prevention, and focus on the areas where improvement is needed most. Rather than applying broad solutions all at once, we use data to prioritize opportunities, test targeted interventions, and measure results. This stepwise approach helps organizations refine what works, scale successful changes, and build a stronger, more effective prevention program over time. Using the Plan, Do, Study, Act framework, our team partners with your organization to define goals, measure where changes lead to improvement, test practical solutions, and refine performance over time to achieve better outcomes. While these cycles may include the Provisio SIM scanner and PIPA, the primary focus is on delivering high-quality care, improving patient outcomes, and creating value for the organization. The plan phase is the longest and most critical part of the rapid change cycle. It establishes the foundation for success by securing approvals, defining the intervention, engaging key stakeholders, and setting measurable outcomes within a clear timeline. Test to change should begin on a small scale, such as 1 unit over 1 month, with a clearly defined workflow, reliable baseline data, simplified inclusion criteria, and integration into existing nursing assessment and care routines. The do phase focuses on implementing the plan and collecting data. Data collection should remain focused, efficient, and sustainable. Establish a clear method for tracking patient trends, assign accountability for completing and collecting documentation, and create a secure process for data storage. In most cases, the electronic health record is the most effective data source, provided all HIPAA requirements and ethical standards are met. Smart forms and web-based data collection tools can further improve consistency, efficiency, and data quality. The study phase focuses on analyzing the data and listening to what it reveals. Identify meaningful trends, connect clinical outcomes to financial impact, and develop a compelling story that resonates with clinical, financial, and operational stakeholders. Finally, the act phase focuses on responding to what the data shows. If the results demonstrate clear improvement, adopt and spread the change. If the findings are promising but not yet definitive, adapt the intervention and test again. If the intervention is not delivering meaningful value, discontinue it and move on. So let's look at a real-world example of how the Path to Zero works to reduce avoidable pressure injuries in a large magnet-designated academic medical center who's pursuing zero harm. Path to Zero begins with a comprehensive data-driven needs assessment whereby all relevant areas of clinical practice are assessed. The needs assessment provides a clear view of the current state, the desired future state, and the steps needed to close the gap. A comprehensive needs assessment begins with clear, accurate baseline data. This is essential for identifying the right improvement opportunities and for measuring the impact of change reliably over time. From a pressure injury prevention perspective, organizations should track total avoidable and reportable HAPIs, variation by unit, monthly trends, leading causes, device-related injuries, skin tone as a risk factor, and associated cost. Our HAPI dashboard provides a clear data-driven view of where improvement is needed most. The data shows substantial opportunity for progress. The organization recorded 336 total HAPIs, representing $15.36 million in treatment costs. Of these, 302 cases, or 90%, were classified as avoidable, and 49.1% were reportable. Together, these findings indicate that a significant share of both patient harm and financial burden may be preventable rather than clinically unavoidable. So we set a long-term goal of reducing HAPIs by 50% through targeted sequential 30-day rapid test of change cycles in 12 months. The data also shows that 64.9% of the HAPI burden is concentrated in the sacrum and heels, indicating a significant anatomical area of risk. It also highlights incomplete skin assessment as a primary driver of injury. In addition, 88.6% of HAPIs occurred among patients with darker pigmented skin tones, further underscoring the impact of incomplete skin assessment and the need for more consistent, effective evaluation practices. By care settings, HAPIs are most prevalent in the ICU, followed by med-surg and oncology, then step-down and the perioperative setting. At the unit level, the MICU has the highest number of HAPIs, and 95% of those patients are admitted through the emergency department. To drive meaningful improvement, we began by focusing on the areas with the greatest prevalence and operational impact. For this reason, we focus our first rapid test of change on the ED to MICU transition. This is the right starting point because it accounts for 70 of the organization's 336 HAPIs, with 95% of those patients being admitted through the emergency department. As we move through this example, notice how a focus change in one high priority area can drive broader system-wide impact. We selected the Provisio SIM scanner as the evidence-based solution to strengthen skin assessment and close the gaps identified in our analysis. This decision was driven by three key findings. Most of our pressure injuries occurred in the sacrum and heels. Incomplete skin assessment was a primary driver of harm, and a disproportionate share of injuries occurred among patients with darker skin tones. We needed a solution that would make assessment more comprehensive, more objective, and more equitable. The Provisio SIM scanner is the only non-invasive skin scanning technology that is FDA approved for pressure injury management. It provides a validated objective assessment of tissue at the sacrum and heels, where the majority of pressure injuries occur. It works across all skin tones and supports anatomically specific and individualized care. It can be incorporated into routine care in just 2 to 5 minutes. Most importantly, SIM scanning helps improve the accuracy and consistency of skin assessment by identifying non-visible pressure injuries 3 to 10 days before damage becomes visible. This supports earlier intervention, improves present on admission documentation, reduces misclassification, and strengthens overall prevention efforts. It is also backed by a strong body of evidence, making it a practical and credible solution for addressing identified practice gaps. Step 2 in the path to zero is to design the intervention for our first 30-day ED to MICU rapid cycle change. The current state is 70 HAPIs, and the goal is to reduce sacral and heel HAPIs by 50%, bringing that number down to 35. The bridge to change is straightforward. Begin prevention earlier in the ED and strengthen skin assessment with SIM technology as patients transition into the MICU. This approach targets the highest risk patients at the earliest point possible. It improves detection and documentation and creates a focused, measurable test of change that can be evaluated and scaled if successful. Now that the data has identified our greatest opportunities for improvement, we are ready to formalize the first rapid change cycle. Let's walk through our plan step by step. I believe that naming things gives them life. This includes evidence-based projects. For this ED to MICU initiative, the project is titled Reducing HAPIs Through Enhanced Equitable Skin Assessment with the Provisio SIM Scanner in 30 Days. The project owner serves as a central point of accountability, and key stakeholders include ED and MICU nurses, unlicensed assistive personnel, educators, WOC nurses, and unit and senior leadership. Unlicensed personnel are intentionally included because they can perform the scans and work collaboratively with the RN to support timely intervention and complete documentation. Educators lead staff training and competency and guide workflow integration. WOCNs ensure the integration of best practices and that all interventions are both on-label and evidence-based. And leadership ensures accountability of staff, achievement of outcomes, and implementation of the full plan over time. Engaging all relevant stakeholders early helps ensure the work is practical, coordinated, measurable, and scalable. Our background shows 70 HAPIs in the past 12 months, particularly at the sacrum and heels, with a disproportionate impact on patients with darker skin tone. So our aim is clear. Within 30 days, reduce avoidable and reportable sacral and heel HAPIs in the MICU by at least 50%. The design is a prospective 30-day quality improvement implementation that integrates SIM scanning into prevention workflow. The objectives of this rapid cycle change are clear and tightly focused on the immediate task at hand. First, we aim to strengthen skin assessment and pressure entry detection through SIM assessment. Second, we want to reduce sacral and heel HAPIs through early detection and more targeted intervention. Third, we are working to improve equitable detection and prevention for patients with darker skin tones. And finally, we aim to reduce unnecessary HAPI treatment costs by preventing harm before it progresses. Defining the setting, population, and inclusion/exclusion criteria clearly helps ensure the intervention is applied to the right patients, the workflow is standardized, and the results are reliable and measurable. The project takes place in both the emergency department and the medical intensive care unit among eligible adult patients admitted or transferred during the 30-day implementation period. Included patients had to be adults, have intact skin over the sacrum and heels, and have no callus in the areas to be scanned. These criteria are important because they ensure SIM assessment is used appropriately and consistently. To evaluate success, leaders must measure more than HAPI rates alone. The initiative tracks both clinical and operational outcomes to capture its full impact. Clinical measures include total and avoidable HAPI, injury severity, early identification of tissue damage, SIM and intervention compliance, time to scan, and documentation accuracy with results reviewed by skin tones to assess equity. Operationally, we examine cost avoided, bed days released, preserved reimbursement, return on investment, and readiness to expand to additional units. Data was collected at baseline, monitored weekly during the 30-day implementation, and reviewed after completion. The project was confirmed as exempt from IRB oversight and was conducted in full compliance with HIPAA. A clear timeline is essential to disciplined execution. It keeps the team aligned, ensures accountability, and helps the project stay measurable, organized, and on track. In this example, at -2 weeks to 0, we focused on planning, training, and baseline data collection. Days 1 through 30 are the live SIM-guided implementation period with a midpoint touch point around day 14 to assess progress, reinforce practice, and address workflow barriers in real time. Weeks 5 and 6 were dedicated to post-implementation analysis and dissemination. The third step in the path to 0 and the beginning of the do phase within the Plan, Do, Study, Act framework is staff education. For our ED to MICU project, we used a multimodal training approach that combines evidence-based practice, adult learning principles, and product mastery. Training, teach back, and teletraining are used to build staff confidence and competence with a best practice goal of training at least 80% of key stakeholders. To date, 88.9% of the expected users were trained, and 100% of the super users demonstrated competency before implementation. The do phase is also where the change is implemented. For our ED to MICU rapid cycle project, we incorporated practice surveillance, targeted microlearning, and timely remediation. This approach helped our team stay aligned with the plan, address barriers in real time, and continuously strengthen performance as the work progressed. Step 5 on the path to 0 is measuring success. We evaluate results across 3 dimensions: clinical impact, workflow performance, and financial value, with statistical analysis used where appropriate to confirm that outcomes are unlikely due to chance. In this project, 253 patients were assessed through 3,600 scans, contributing to an 87.9% reduction in sacral and heel HAPIs. A one-sided p-value of 0.02 further supports that these results are statistically significant and unlikely due to chance. In addition, 75.6% of patients scanned in the ED showed elevated SIM deltas on admission, strengthening present on admission differentiation and supporting earlier, more equitable detection of tissue damage. Workflow performance was equally strong, with scan times under 1 minute and high staff confidence in both usability and intervention, greater than 90%. From an executive perspective, the 30-day rapid test of change delivered an estimated net savings of $231,700 after project cost, with an annualized net savings of approximately $2.8 million. The sixth and final step in the path to zero is dissemination, where local improvement begins to drive broader impact. We start by sharing results with internal stakeholders, including nursing leadership, wound care, quality teams, and frontline staff, while securing approval to spread and scale our success. We then tailor the message for broader dissemination, beginning with an SBAR for operational updates and key outcomes. The same content is then adapted into an abstract for internal presentation and external conferences such as ANCC Magnet, and ultimately a podium presentation or manuscript. Dissemination strengthens our credibility, demonstrates commitment to quality, and helps others apply successful practices in their own settings. Because our key indicators of success were achieved, the next step is to scale the success. That means sustaining the workflow in the ED to MICU pathway, then expanding it sequentially to other ICUs, followed by med-surg, step-down, and perioperative areas. The key is to stick to the plan, standardize what works, and revise only where the data shows refinement is needed. In our ED to MICU example, Path to Zero transformed prevention from a broad aspiration into a measurable, repeatable, and scalable care pathway. Success begins with a clear assessment of the current state, followed by identifying and prioritizing the greatest opportunities for improvement. Teams then set SMART goals and use data to guide every decision. Change starts small, with a focused 30-day test in a single unit, but it is built to scale. Before go live, protocols, training, and documentation are aligned to create consistency and accountability. During implementation, surveillance, microlearning, and weekly review allow teams to respond quickly, strengthen performance, and accelerate results. So you're probably wondering whether rapid tests of change can deliver meaningful results beyond a single example. The answer is absolutely. So let's briefly look at how Path to Zero has been applied in real-world settings where rapid tests of change have delivered measurable outcomes. Case 1 highlights a large academic medical center and magnet exemplar that implemented a two-phase SIM-guided pressure injury prevention initiative across 4 high-acuity units. Phase 1 included 2 step-down units with admission and daily scans, followed by 2 ICUs who scanned on admission and 3 times weekly. Starting from a pre-project average of 6 HAPIs per month, the program achieved a 67% overall relative reduction, eliminated HAPIs entirely in 2 of the 4 units, and avoided $217,000 in treatment costs over 30 days. Case 2 highlights a community hospital ICU with 18 beds, where 107 patients were included and more than 1,000 SIM scans were completed. The goal was straightforward: reduce HAPIs. Over the 30-day period, no HAPIs occurred. The data also showed that 76.6% of patients had elevated SIM deltas on admission, and 32 had deep tissue pressure injuries present on admission. Even in this setting, the program delivered measurable value, including $35,000 in net savings in 30 days. Case 3 highlights an urban academic safety net medical center with 4 ICUs that continue to experience persistent HAPIs despite multiple prevention initiatives. SIM scanning was added directly into the critical care pathway, with scans documented in Epic to support consistency and visibility. The result was 0 HAPIs across all 4 ICUs, along with 40% reduction in sacral and heel HAPIs sustained over 2 years. The project owner reported that this is the first time in more than 20 years that all 4 ICUs reported 0 HAPIs. Case 4 features an academic medical center oncology unit where 147 patients underwent 576 SIM scans, all in support of a 0 harm goal. No HAPIs occurred during the project period. The data also showed that 78% of patients had elevated SIM deltas on admission, and nurse acceptance was exceptionally strong, with up to 100% agreeing that the technology was easy to use. Financially, the program delivered an ROI greater than 241%. Case 5 comes from a high-fidelity, magnet-designated academic medical center with 5 ICUs, despite a robust pressure injury prevention program. SIM helped clarify that 2 of 3 HAPIs were present on admission, improving diagnostic accuracy and documentation. The outcome was 0 HAPIs in 4 of 5 units, demonstrating that even mature programs can achieve better results with more objective assessment. Real-world application can deliver real-world outcomes. Through these rapid tests of change and the Path to Zero partnerships, SIM-guided pressure injury prevention achieved a 91.8% overall relative reduction across various care settings and regardless of the quality of the PIP program. Across all 5 real-world examples, the pattern is clear and consistent. Combining SIM with Path to Zero advances organizations towards 0 harm, reduces waste and costs, and delivers rapid return on investment. Whether in academic, community, or safety net settings, objective assessment paired with disciplined implementation produced measurable clinical and financial results. What stands out is the consistency of the outcomes. Movement towards 0 or near 0 HAPIs, strong value from objective SIM-based admission assessment, success across diverse care environments, measurable financial return alongside clinical improvement, and a repeatable implementation model.
Thank you. Thank you for those in attendance for joining us today. And a big thank you, Dr. Sullivan, for sharing your experience and your insight this afternoon. As many of you are on the line here, as you think about your path towards 0 pressure injuries, we hope that today's discussion gave you a few ideas that you can take back and apply right away. If it would be helpful to talk through how that might look in your organization, we'd be happy to chat with you. Please feel free to reach out to Rhonda, Karen, or myself. Our contact information is on the screen. As always, we'd love to open it up to questions. We know we're coming up on time, but if you have some questions, maybe put them in the chat. As people start to type those questions, what I'd also like to do is share with you a little bit of information about our next webinar. The next webinar is titled Pressure Injury Prevention Technology, a clinical guide to what works, what's cleared, and what to ask. We hear every day from clinical leaders and nurses that they are confused about all the different pressure injury prevention technologies on the market today. The intent of this webinar is to give you an objective overview of the technologies, the regulatory status, and the science and clinical evidence behind each technology. If you or anyone on your team is struggling to understand the difference between SEM measurement, thermography, and near-infrared spectroscopy, this webinar is for you. We hope you'll join us. And as always, if you can't make it live, sign up and we'll be sure to send you a recording and a summary. Okay, let's go see if there's any questions.
No questions that I can see so far.
I don't see any either. So it is 1:30. Let's stay on in case there's some questions that come in. I know there's still a number of people in the meeting here. So if you have a question, feel free to ask. Sometimes it's that first question that gets some other questions coming in. But if you have a question about rapid tests to change, some of the case studies that Rhonda shared, what this might look like in your facility, ask the question and we'll do our best to answer it.
No questions.
Rhonda, you talked about, once you have success on a unit, then kind of expanding from there. Can you talk about, I guess, what does it look like? Let's say you had success on the ED to the MICU. What do you do, or what do you learn from that first rapid test of change, and how does it change what you do in that second implementation?
I think the most important thing that you learn is what works and what doesn't. And that's really foundational to rapid cycle change, is really looking for those opportunities to improve the process. One of the things that we do quite often is we're always asking the nurses, tell us what's working, tell us what's not working. And so that two-way communication allows us to adapt what didn't work and make it better for the next cycle and the next cycle and the next cycle. And it also helps us to refine even just the protocol. What works in one unit may look different in another unit, but at least we have a strong foundation of what's working to build on. The other thing is really understanding your facility's processes for moving a project forward. Is that presenting to VAC? Is that presenting to your CNO? Who are the people you need to present your outcomes to move that project forward? Because I find a lot of the frontline staff don't really have visibility to what they need to do next. We're good at doing clinical projects and producing outcomes, but we're not really good at sharing our successes, celebrating ourselves, and also spreading that information to the people who can help us make bigger decisions and move the projects forward.
Yeah, I think that's spot on, Rhonda, from some of the experiences that we've had. And what we want to let folks know is lean on us. If there's things that we can do to help, to prepare information, to provide information, to have conversations with other key stakeholders within the organization so they understand what you're doing and what the desired outcome is. And if you get that desired outcome, the financial benefit to the organization, that's where we can help. So I think it's, a lot of good information.
There's a question in the box too, sorry.
What's that?
There's a question in there. I'm going to try to answer it.
Oh, okay.
So the question was, I know you're having another webinar in May for this question, but high level difference between this and other technologies. And I think the most high level differences are, Bruin Biometrics, the Provisio SIM scanner is the only non-invasive skin scanning technology with FDA clearance for pressure injury management. If anyone else is telling you that you can use their technology to detect pressure injuries, they're asking you to use that technology off-label, which puts your organization at risk. The other difference is the body of evidence. There are 209 plus pieces that supports Provisio SIM scanner and SIM assessment as a best practice for pressure injury prevention. If you look at the other technologies, what you'll see is they have very little to no evidence on pressure injury prevention, and most of them have no high-level evidence for pressure injury prevention. So the biggest things would be evidence and FDA clearance, so that you're not putting your organization at risk.
And Rhonda, those are two important ones. One I would add to it is kind of the science, right? As an organization, we've spent years really kind of understanding how pressure injuries happen, and in our device is actually identifying a biomarker that's occurring underneath the skin that's actually part of the pressure injury damage cascade process. And by identifying that biomarker, what it allows us to do is to actually empower the clinicians to identify non-visible damage at least 5 days before it's visible on the surface of the skin. And so what I would say is there is a science, there's a biomarker that we're identifying, and it's an objective score that provides the clinician with information that they can then use in order to change the way in which they care for their patients. So I think this next webinar, Rhonda, is going to be a packed webinar, and I'm sure we'll have some questions during that webinar. But I think that we got maybe a little bit of an early previews from some of the information that we might share during that webinar.
Yes.
Let's see if there's any questions in the other box. In the chat box, doesn't look like there's any questions. I know we're 6 minutes over. So again, for those online, if you haven't, maybe now's the time to take a snapshot and register for that next webinar. I think it's going to be an interesting one. And if you did register and you'll get the link to the video, you'll be able to share that with other colleagues that maybe weren't able to attend. Thank you all again for your time today. And Dr. Sullivan, thank you so much for the presentation. Greatly appreciate it.
You have a great day.